Excited to learn things about people that I thought I knew. They're always way more qualified and way more eminent than I even thought they were. So today we've got the Duminda Wijeysundera, and I don't usually say your last name, so
yeah,
but you
got it right on.
Okay. He's a staff physician at part of Anesthesia at St. Michael's Hospital, is scientist at the Shing Knowledge Institute at St. Michael's Hospital, and the endowed chair in translational anesthesiology research at St. Michael's Hospital and U of T as well. He's a professor in the Department of Anesthesia and Institute of Health Policy Management and Evaluation at U of T, adjunct scientist at ICES Central, and his research program focuses on developing methods to better predict and prevent medical complications following major surgery. And that seems what you're talking about today, preoperative assessment of people, see if you can predict outcomes after surgery. So would you like questions as we go, or do I save them for the end?
I can do either, as long as we're not running over. Is there clock grows? I can look at my own just to make sure I'm not getting too late in the program. Okay, but I'm happy either way.
Thanks very much.
Great. Thanks very much, George. So I think what George didn't mention is, like, I've known him for a very, very long time, and both as a grad student, but he actually supervised my wife's PhD, and he still works with her. And like most men, I think the smartest thing I did was marry a woman smarter than me. So George knows that well. So I'm going to talk, as you mentioned, what I'm going to be talking about is a large part of it will be focused on the results of the study we recently conducted and completed, but also more generally in terms of the clinical and methodological issues with regard to risk assessment in surgical patients. I don't have any major conflicts of interest, and these are just the various sources of support that allow me both to be outside the operating room and to support my research program. And this is an outline of what I hope to cover in the presentation. So we're going to talk a little bit, I guess, from a general perspective about why people who take care of surgical patients, be they surgeons, physicians, or anesthesiologists, are interested in evaluating their exercise capacity or functional capacity before surgery. I'll then talk a little bit about the validity of the current approach that we use for assessing functional capacity typically, both with respect to being a true measure of exercise capacity and to also risk stratify patients accurately with respect to their risk of having postoperative complications. I'll discuss some other potential approaches for assessing functional capacity in surgical patients, and then talk about the design and results of the MET study, which is the study we recently completed. And I'll touch on at the end with some sort of issues that I think are still relevant for future research in this area, because like many things in what we call perioperative medicine, there are more unanswered questions than there are answered questions. So maybe to begin with, what is the intended role of even assessing functional capacity or patient fitness before surgery? And sometimes, you know, when I tell friends of mine who are not in medicine that this is one of the things that I do for research, they kind of look at me in a befuddled way. Well, obviously, a patient who's less fit is at higher risk. So this seems a bit like, if you watch Hotels.com advertisements, they look at me like I'm Captain Obvious. But I'll give you at least 3 reasons why I think it matters. The first is that just about everybody who takes care of surgical patients or assesses them before surgery asks these patients a series of questions similar to these 4 questions. And on the basis of their responses, we try to make a judgment about how fit or unfit they are. And then typically we believe that patients who have less physical reserve or exercise capacity reserve are the same patients who are more likely to run into trouble after surgery in terms of dying or having major complications. So it's something we do typically in practice. It also has major implications, or is certainly integral to a lot of clinical practice guidelines. And one key example are the guidelines for cardiac risk assessments for patients having surgery. This is the algorithm for the major American guidelines from the American Heart Association and the American College of Cardiology. It's not a very straightforward algorithm, but let me just put it to you that if you look at a major box right here, there's a whole series of decisions that are based on what you think a patient's fitness might be. So essentially, if you think somebody is capable of more than 4 metabolic equivalents, which is about climbing 2 flights of stairs, they suggest that you can simply send those patients forward to surgery. You don't have to do any further testing or evaluation to delineate their cardiac risk. So a lot of that decision making is informed by physicians' judgment of patients' functional capacity. And finally, the assessment of functional capacity allows us to overcome, or at least theoretically overcome, a lot of limitations about the typical tools we would use to assess patients' risk. So any clinician taking care of any patient in a clinical setting, you can get information simply by talking to them. So not unlike many other areas in medicine, there are clinical prediction tools that have been developed in perioperative medicine. And I'm showing here one that's typically used for estimating patients' risks of having cardiovascular complications after surgery. So this is having a heart attack, having heart failure, having a significant arrhythmia. And the one tool that is really typically used is one that's called the Revised Cardiac Risk Index. It's a very simple tool. It's actually an update of the Goldman Index, which was developed by Lee Goldman, and subsequently the Detsky Index, which was developed here by Alan Detsky and others. So one of the reasons why it's very commonly used is it's simple. There's 6 components. If you have one of those items, you get a point, and the more points you have, the higher the risk it is, higher your risk of having events. And it's been validated in a number of studies, and has shown pretty stable discrimination. And essentially, if you've got 0 points, your risk is pretty low. If you've got 3 or more points, your risk is high. And you got this kind of group in the middle where your event rate is about 2%. You're not sure typically what to do with that. One of the problems, though, is that typically in most studies that have validated this, the vast majority of patients, so about 50 to 60%, end up in that intermediate risk group. So you have a lot, and you encounter this in clinical practice where you apply this tool, and you're kind of left in this gray zone where you're not sure. They're not really low risk. They're not really high risk. What do I do with this? And so one, I think, conceptual reason why we use functional capacity is if you have groups of patients, where you might delineate them as being high, medium, or intermediate, high, low, or medium risk, hopefully, by using functional capacity, you can push more of those people to the margins, to either high risk or low risk, where our decision-making outlines are a bit clearer. So why would you want to be interested in functional capacity as a method for doing that? Well, there are some data. So most of these data, at least with respect to exercise capacity, are actually pretty dated. So if you look at the American Heart Association guidelines, the one where they place a huge emphasis on estimating functional capacity, the studies they cite for this are 2 studies. The latest was about 1998, about 350 patients in total, and essentially looked at patients who had a typical exercise test and where they measured their exercise capacity, and then they looked at their risk of having a heart attack or having death due to cardiac reasons after surgery. And they essentially found that patients who had more than 4 to 5 metabolic equivalents, or METs, had a very low risk of having these events. So there are some data. They are pretty limited. Probably the larger body of evidence actually comes from studies where people did something like this. So for most people in North America, we're not sure what that is. If you work in cardiac rehab, you'd recognize this. So this is what's called a cardiopulmonary exercise test. We actually do a lot of these at TRI, at the Rumsey Center. So it's a exercise test where, in addition to blood pressure monitoring and heart rate monitoring, you typically wear either a face mask or a mouthpiece or a nose piece. And while you're exercising, you get a measurement of your oxygen consumption and your carbon dioxide production. So you can use it for measuring fitness or sort of cardiopulmonary fitness in frail patients, medical patients, but actually it's also a test that elite athletes will do. So if you're a Tour de France athlete, for sure you would have done a test like this. So you'd obviously do a lot better than most of the patients we see in hospital. It's a very rich set of physiological data come from these particular tests. But there are typical metrics. One is called VO2 peak, or peak oxygen consumption, and another one called the anaerobic threshold. And higher values denote higher levels of fitness. And those are the typical metrics used for measuring fitness using this test. Why does this matter? Well, there's actually a relatively large body of literature, mostly from the UK, where this, unlike stress testing or echocardiography, is the most commonly used sort of physiologic exercise test for patients awaiting surgery. So about 60 to 70% of NHS trusts, certainly in England, have a cardiopulmonary exercise testing service specifically for evaluating patients awaiting major surgery. So it's really commonly done. And there's a bunch of historical and organizational reasons why this is the case. But a lot of those centers have actually published registry results and have shown, so these are documentation of basically what happens in usual clinical care, that patients who have poor performance on this test based on a low anaerobic threshold or low peak oxygen consumption, those patients were more likely to die or have major complications after surgery. But it's often been the major justification for why they continue to do this test, certainly in the UK. So what are some of the limitations of those data when we looked at this a couple of years ago? Well, they were predominantly registry-based studies, so they simply looked at databases of all the patients who had testing as a matter of routine care. So very few of them actually blinded the results of the cardiopulmonary exercise test from clinicians or outcome adjudicators. So sometimes the decision to proceed with surgery was based on CPET results, the type of care, the type of monitoring they received afterwards. So at least methodologically, there's some issues with that. All but about 2 of these studies actually came from the UK. The others are Australian studies. And to the extent that people care about generalizability, there's often been a reluctance, certainly in North America, to some extent also in the rest of continental Europe and many parts of Australia, whether these results would be extrapolatable to other centers that don't do this type of test as often. And something that wasn't considered much is I'm really talking largely about prediction of cardiovascular complications after surgery. Most of the bad things that happen to patients with poor performance on these exercise tests were infectious or pulmonary complications. So pneumonia or respiratory failure or site infections, far fewer of them were actually cardiovascular events. There's often been the focus in terms of preoperative risk assessment. So we don't do any of those. We don't do complex tests typically in preoperative care. We do questions, as I mentioned before. So you can see, if you look at those questions, and these are sometimes more or less than what many clinicians would do in typical practice, there are a number of concerns, or at least questions you'd have about the validity of that approach. So what might be them? First is that there are probably a lot of variability in the way people ask those questions. So depending how busy I am in clinic or my colleagues might be, we'll ask 2 questions, 4 questions. I suspect most people don't ask more than that. And these are all based primarily on the objectivity of patients' own perceptions about their physical activity. They may tell you they climbed 2 flights of stairs, but they won't tell you how long it takes, or that they only did it about 2 months ago at the most recent time. So it has implications, at least with respect to the ability of usual clinical care or asking questions for actually measuring true exercise capacity and for actually risk stratifying patients. So how much data are there for this? And interestingly, to go back to my ClinEpi training, I was taking a course with when Dorcas Beaton and Eileen Davis ran the clinical measurement course when I was a grad student. One of the things I was evaluating the revised cardiac risk index, so we were looking at how well it performed as a measurement tool. But one of the questions we did is, could you actually incorporate assessment of functional capacity into this? So when I looked at this, we actually found there's very, very few data on this. And these are just two of the very few studies that have looked at it. So to what extent does our physician's examination or questioning of patients reflective of their true exercise capacity? This was only published as an abstract. This was at a center in the United Kingdom where they actually did cardiopulmonary exercise testing in patients. And what you see here on the x-axis is performance on a cardiopulmonary exercise test based on anaerobic threshold, so values to the right indicate higher levels of fitness. And on the y-axis, you see what the anesthesiologist's judgment of what their fitness might have been based on their responses to typical questions. And they looked at the correlation between the two. And the Pearson R was 0.31. And even if you don't do statistics on this, I think most of us would agree this is not the greatest correlation one might actually hope for. So it doesn't appear, based on limited data, this is again, I think 60 patients, that physician's judgment was a great correlate of true exercise capacity. So it then follows, well, to what extent does it actually measure or predict outcomes? Again, much fewer data. This is the largest study, which was a retrospective cohort study from a single center in the United States, where they took information from their hospital records and looked at the correlation between the anesthesiologist's judgment of patients' fitness, again documented in what's called METs, and they looked at the relationship between that and the patient's risk of either dying or having cardiac complications in hospital, and they looked at the correlation, the predictive ability or discrimination using an area under the ROC curve. And importantly, the cardiac events that were documented here were ascertained just using IPD9 codes in the administrative data. So if you looked on the left, that's the ROC curve for predicting cardiovascular complications. That area is 0.66, acknowledging that that definition or ascertainment for the outcome is not the best. But if you looked at death, which should be coded pretty accurately, that area is 0.52, and I think all of us know that's not particularly good. So when we looked at these data, so although it seemed like at first when we looked at it, it seemed a bit like Captain Obvious research, when you actually look at the data for something that was so integral to perioperative care, at least we didn't know how good something that we did all the time actually performed in terms of doing what we intended to do. So are there alternatives? And these are a couple that we thought of. So one was actually the cardiopulmonary exercise test. And if you looked at folks in the UK, they would say you should just move on to this and expand your exercise testing program, because they believe very strongly that this is the better way to assess physiological fitness and use that to determine who's going to run into trouble after surgery. But the problem with that is that it takes resources. So you need the exercise equipment, you need software, as well as specific metabolic cards to actually detect CO2 and oxygen, to calculate these various measures of VO2 peak and anaerobic threshold. You require specific training, and none of these are free. So there are some incredible resource implications, and certainly I suspect in most healthcare settings, this is not a service that we can provide to all patients presenting for surgery, because there's so many of them. Another approach is one of actually dealing with the variability in how we ask questions. So we just kind of do it in an ad hoc manner, depending on what your usual clinical practice is. But we also recognize that there have been a number of standardized questionnaires that have been developed, such that they have psychometric properties where it was at least correlated on patients' objectively measured exercise capacity. Now, there's a bunch of them that have been developed that are either general or for heart failure patients or patients with coronary artery disease. The one we focused on was actually the Duke Activity Status Index questionnaire. So for those of you who aren't familiar with it, it's a 12-item self-reported questionnaire, yes or no answers, and the score ranges from 0 to 58.2, probably not the most user-friendly way of converting numbers. But it was developed originally by Mark Klatsky and colleagues in a sample of patients, outpatient patients with stable coronary artery disease. And in that study and most subsequent studies, there's been at least moderate correlation between your DASI score and your performance on objective exercise testing. The reason we selected this was it was relatively simple. It's actually informed a lot of the questions in guideline documents for perioperative care. So some of the questions people recommend that you ask patients, actually are questions drawn from this questionnaire. And there's been some extent of validation work done in surgical patients. So this was a study, a prospective cohort of about 80 patients having major abdominal surgery in the UK. And they got patients to complete the DASI questionnaire, which is what you see on the x-axis. On the y-axis, that's peak oxygen consumption on an exercise test. And that correlation coefficient in that particular study was about 0.68, which is consistent with what has been demonstrated in the literature. So this may be not perfect, but certainly better than the way we ask questions normally. What are some of the problems with that? The first is that we kind of know that a DASI score of 50 is better than a DASI score of 40. But if you try to take a score and convert it to actual VO2 peak, there are conversion formulas that have been published. But there's been a lot of variation about what the appropriate way to convert that is. So there's a typical conversion formula where you end up with a score from about 0 to 10 mets, but there's been others that have been used in other studies and been shown to be a better way of converting that. So there is, if somebody asks me or an expert, like, what is a DASI score of 35 correspond to, there's some uncertainty about that if your interest is actually figuring out what somebody's estimated VO2 peak or exercise capacity might be. Now, the last approach is an approach that is increasingly common, certainly in perioperative care, which is to move from exercise tests or history to simply doing blood tests. And this idea of just using biomarkers to compensate or just replace all of these. There's probably no single blood test that is reflective of true exercise capacity. The one that we thought would be the best indirect measure is very natriuretic peptides or NT-proBNP or BNP. So these are peptides released by the heart in response to anything that makes the heart work harder. So if there's ischemia in the heart, if there's increased wall tension, you secrete more of these. So people who have higher levels of this they have people where their hearts are working hard to do the same level of activity. This has a huge role, certainly, in the heart failure setting, where it's been used to be able to figure out whether somebody with shortness of breath has heart failure or something else. It also has prognostic features in patients with or without heart failure. But what's been increasing done over the past decade or so are studies where these peptides were measured in patients awaiting major surgery, and there was then a determination of the extent to which those preoperative levels in those peptides predicted whether they had cardiovascular complications after surgery. And a lot of this work has been done actually by the group in McMaster University, led by PJ Devereaux and colleagues. This is the most comprehensive systematic review that's been done on this. So it was an individual patient data meta-analysis. So it sort of did this typical analysis, which just said, did natriuretic peptides help predict cardiovascular complications? It did. But what it also did was actually perform some degree of net risk reclassification analyses to figure out to what extent did natriuretic peptides improve prognostication when added to typical clinical risk factors which have been identified. And certainly if you extrapolate the results based on the net risk reclassification numbers, what it would suggest is that if you took 1,000 patients and you estimated their risk using clinical risk factors and you repeated that after adding natriuretic peptides, you'd identify, assuming a baseline event rate, which they had of about 12%, you'd identify about 8 more patients who are truly high risk. So these were people who had an event, but where the addition of natriuretic peptides helped move their risk estimates in the correct direction. So not actually that impressive. Where it seemed to work much better was better identifying low-risk patients. So there would be 63 where they would not have had an event, where clinical risk factors would have suggested that they were at higher risk than you would have actually thought on the basis of using natriuretic peptides. So these are typically, if you look at the data, better for screening out low-risk patients, but there's been a huge push for this. And there's actually been a recent set of guidelines, which are Canadian-based, which actually suggest that we should be using these biomarkers in just about every patient presenting for major surgery. And there's just some centers in Canada which are doing this and using this to supplant other methods for risk assessment.
That's a question before you go into what you did. So what about something, so that I understand the resources needed for the exercise test on the bicycle, what about something simple like a 6-minute walk test?
That's a great question. So I'll get to that at the end. But so people have done 6-minute walk tests. We actually did a study of this, which I'll get right to the end. But the data thus far would suggest that the studies have been relatively small, but the studies that have been conducted thus far looking at the relationship of the 6-minute walk test and outcomes after surgery have been mixed, and the majority have shown no relationship with complications. One of the problems with the 6-minute walk test is that, unlike cardiopulmonary exercise testing, where you have somebody encouraging them to do the test retest reliability is actually pretty good, because if you see somebody being pushed on CPAP, they push them hard. Whereas the 6-minute walk test can have a 15% improvement with repeat testing because there's a learning effect. And most studies in the surgical setting, understandably, they just do one 6-minute walk test. So there's more of a signal to noise ratio with that test. So these were the things,
We looked at the previous blood test, they looked at the cost effectiveness of that, because you're actually only getting an incremental of 71 individuals after testing 1,000 to try and do the work. So what's the cost of trying to put that into implementation? So very little gain, right?
It is, and it's also contingent on there being sort of what might be viewed as actionable information, right? So there has been some work done on that. It's again come from the group at McMaster, which would suggest it is superior to certainly doing cardiac stress tests, and that's probably fair, right? So that is probably fair. But all of those are predicated on the assumption that that information is actionable. Now, that's a problem in general in heart because we don't have therapies. So I can't remember the numbers, but the comparator was stress testing. To that, it's obviously it's but yeah, that's
your clinical judgment. Like, how much are you going to gain if it's solely clinical data? How much are you going to incrementally gain from a judgment call on the individual versus just?
I would suspect for a completely non-selected group, I don't think it's much, and probably not for a test that is. These tests are $35 to $50. It's not when the denominator is high, given the number of surgical patients we have. So I think that's another major implication. So these are the 4 things we looked at when we were designing the study, and this was a group of us, not just here in Canada. So it was co-led by myself and Brian Cuthbertson, who's a critical care physician at Sunnybrook, but folks in the UK and Australia, and a large group of people here. Actually, John Granton and Paul Lowe here at UHN and TRI. So we tried to focus on the 4 things that we thought had the highest yield. And so first was just usual physician judgment, and by physician, it's anesthesiologists. Some would argue that perhaps anesthesiologists were not the best judges of fitness, but if the anesthesiologist saw the physician, the patient, formal cardiopulmonary exercise testing, the Duke activity status index questionnaire, and biomarkers. So this was NT-proBNP, which for people in the space, they would argue that NT-proBNP is a bit more stable and a better biomarker than BNP alone. So we simply didn't seek to just compare them to each other, but also to see what additive value did they provide to risk prognostication on top of traditional risk factors. And by this, I meant the revised cardiac risk index. So in terms of what we intended to do, we intended to conduct a multi-center cohort study of about a little less than 1,400 patients. And these are patients having elective major inpatient non-cardiac surgery. So they had to stay in at least overnight in hospital. And they at least have to have one or more risk factors for either having pre-existing vascular disease or having cardiovascular complications after surgery. And as you can imagine, from a design perspective, one of the things we needed to do in this type of study was capture patients at some risk, but also have some spectrum of risk. So if we captured a whole bunch of patients who were completely decrepit, then it wouldn't be very helpful because all their risk would be on one tail end. And it also didn't make sense to get a whole bunch of healthy patients. So it was broad in terms of inclusion criteria to hopefully capture the spectrum of risk. So the measures were physician judgment, and we asked them to judge their fitness in terms of, I think, what we would call sort of typical clinical categories. And I know the acronym for the study is METS, or Measurement of Exercise Tolerance Before Surgery, but METS also is how we often classify patients' exercise capacity. So we asked them to classify them as unfit, less than 4, 4 to 10, which is kind of normal, and greater than 10. They completed cycle cardiopulmonary exercise testing. The primary metric of fitness we used was VO2 peak. They completed DASI questionnaires and blood testing for NT-proBNP concentrations. The sample size calculation originally was done based around a comparison of ROC curves because the formula is just, there are far fewer assumptions you have to make. But we recognize that that's probably not the most statistically efficient way of doing this, and this is where Kevin Thorpe at St. Mike's and Dalalana helped us with. So we also plan to conduct multivariable logistic regression as well as continuous net risk reclassification methods because we recognize that was probably statistically more efficient in terms of use of the data. Yep.
So for the elevated risk of the population, is it back to the first slide where it's more than one? Like is this the intermediate and high group?
Exactly. Yeah. So people who are at least one or more. Yeah. So the outline of the study protocol is kind of what we recruited patients at preoperative assessment clinics. They completed the questionnaire, they had blood testing done. And at some point between that assessment and the day before surgery, they came back for an exercise test, which I can tell you in Canada is one of the most difficult things to do because you have to take a patient who's awaiting surgery and tell them, please come back on some separate day and let us do an exercise test just for pure research purposes. So that we did a lot of work in trying to make that easier, including pay for parking, incentivizing things, but that was often the challenge. And one of the things we incorporated into our sample size estimate was that we recognized we would have dropouts between the time of recruitment and the day of exercise testing because people get anxious, they change their mind, and we knew that was likely to occur. This was less of an issue in the UK, where they often had an exercise testing facility in the pre-admission clinic. They get recruited and they just go down the hallway and do an exercise test. So there were some operational differences across countries. Because this was a study carried out in Canada, but also it was coordinated at the Applied Health Research Centre at St. Mike's, but it was also conducted in Australia, New Zealand, and the UK. So the primary outcome was death of myocardial infarction at 30 days after surgery. The secondary outcome was mortality at 1 year after surgery. But we also had two other major study outcomes, which was death of myocardial injury, which is just a significant troponin elevation. And one of the difficulties with identifying myocardial infarction after surgery is that sometimes you don't do ECGs or capture things at the same time. So people can have troponin elevations that are prognostically important. We know they kind of do worse afterwards. There's a lot of debate whether they are actually infarctions, but we do know patients who have them tend to have worse outcomes over the long term. And what we call moderate or severe complications. So these are complications that occur in hospital that prolong hospital stay or have long-term morbidity on that patient. And importantly, unlike previous studies, we blinded the results of stuff where we could blind them, so the CPET results, the DASI scores, and NT-proBNP. So this was 8 years of work, and so we actually completed that 2 years ago. We published the paper in the Lancet, actually around this time last year. And as I mentioned, this was a huge multi-center effort, so we had 25 hospitals and more than 120 investigators, and many here from Toronto and here from UHN, actually. And on top of that, one of the things I wanted to acknowledge is all the sources of support, which again reflected the fact that it was a multinational study. So we got support actually from funders across the 4 countries involved. So what did we find in the study? So I think, as I mentioned, we anticipated that we would have some dropouts after recruitment to CPET. So although we recruited 1,041 patients, there were about 1,401 who actually had surgery in CPET. And so about of the 240 who were excluded, about 140 withdrew because they just changed their minds. It's kind of anticipated that would happen. There's about 56 who did not have surgery. And this was a typical issue in Canada, to some extent in Australia. There was about 145 where their date of surgery changed, it just got brought up, and there was no way we could reschedule an exercise test within that time. But our eventual sort of primary cohort analysis included more patients than we needed, so we achieved the target sample size. Of that group, all but 2 were followed up successfully to 30 days after surgery, and about 98% were completed 1-year follow-up. So, which is a testament to the investigators and the project coordination folks at ARC. So what are the characteristics of the patients? About 40% were female, the median age was 65. So there are sort of what are typically used in surgical patients is what's called the American Society of Anesthesiologists rating scale. It goes from 1 to 5. 5 is you're dead before you have surgery, and we do see that on occasion, especially when you have surgery here. And 1 is super healthy. 4 is quite it's quite a sick patient. Most of these patients were class 2 or 3, so this is kind of an intermediate risk group, which is kind of what we wanted. About 2/3 of them underwent major abdominal surgery, and about a quarter, unlike many previous studies, actually are getting major orthopedic surgery, which included joint replacement surgery. And interestingly, these patients could actually complete cycler testing despite that. One of the things we tried to figure out was we had one of these little mini cycle testing devices you can buy at Shoppers Drug Mart. We put them in the clinic to just make sure they had enough range of motion to do the test. But they could, the majority of them could actually complete the test, which is an interesting observation by itself. Where it was more difficult is, although our projected event rate was, or in terms of primary outcome, was about, we hoped it to be about 3 to 3.5%, our outcome event rate was lower than that. And to some extent, and we can talk about that later, this is kind of reflective of what is happening with contemporary elective surgery, certainly in a high-income nation. So the event rate for death of myocardial infarction was only about 2%, about 2.5% died within 1 year after surgery. So this, again, is good for patients, but more challenging for studies. Where the outcomes that occurred more often, and this is again in line with what you see for major inpatient non-cardiac surgery, about 12.5% had death or significant myocardial injury after surgery, and about 14% had moderate or severe complications. What was interesting was if you looked at moderate or severe complications, and this is just sort of groups of patients, if you stratify them as having either no or mild complications or moderate, severe, or fatal complications. So we didn't capture all individual clinical events that happen in those patients. But if you look at that, if you just look at myocardial infarction, well, about 5% of people who had moderate or severe complications happened to have a myocardial infarction. Interestingly, there were some who met the definition, but who the clinicians thought, taking care of them, thought actually nothing really happened. They might have had a troponin change, some minor ECG changes. They didn't think it was clinically relevant. But most of the events that were detected clinically by the folks taking care of these patients tended to be respiratory events, so respiratory failure, so reintubation or prolonged ventilation, pneumonia, surgical site infections, about 1 in 5 of patients with moderate severe complications had that, or things such as unexpected ICU operation admissions or reoperations. This is not an exhaustive list of all the things that happen, but certainly these data would suggest that in the cohort, the reason why people have bad things happen to them were often not actually related to cardiovascular complications, which in many ways, upon reflecting on these data, probably reflects kind of my own clinical practice. You rarely see people have a major heart attack after surgery, which is fortunate. You much more likely see people have trouble with respiratory failure or surgical site infections. So it may be reflecting how the epidemiology of complications after surgery has changed over time. These are comparisons of physician's judgment versus objectively measured exercise capacity. So what you see here are box plots of patients stratified as having poor, intermediate, or good exercise capacity based on the anesthesiologist's judgment. This is about 50 patients on the very right where we did not get information on the anesthesiologist's judgment for some operational reasons. As you can see, the box plots show that the distributions are clearly different. So it's not that people had no sense of who was fit, unfit versus fit, but there's a huge amount of overlap between those distributions, suggesting we're not that accurate. And if you actually look at the ability of an anesthesiologist's judgment of identifying whether somebody actually has poor fitness. So poor fitness would be 4 METs or less, which is equivalent to a VO2 peak of 14 or less. So if you use that criteria, then the anesthesiologist's judgment had 19% sensitivity and about 95% specificity. So certainly a great many people who had poor fitness were not detected based on clinical judgment alone. Another question was, would a biomarker simply suffice as a measure of exercise capacity? This shows a correlation between NT-proBNP concentrations on the x-axis versus VO2 peak on the y-axis. Higher NT-proBNP indicates poor levels of fitness, so you would expect some degree of a negative correlation, but it's a pretty weak correlation. So Spearman correlation is about -0.21, which suggests that these measure related but different constructs. And it would also suggest that a biomarker, contrary to some sort of opinion leaders, is not a substitute for measuring exercise capacity if that is what your goal is. And finally, the question is, well, how well does the DASI questionnaire perform in our patients? This shows DASI scores on the x-axis versus peak oxygen consumption on the y. And there is a correlation. It's actually on the lower end of what's been reported in the literature. So the Spearman correlation was about 0.41. Usually in the literature, it ranges from about 0.4 to 0.6 at the upper end, sometimes 0.7. So this is lower than what one would typically see, but it's within the range of what's been reported. The other interesting thing, though, is that as I mentioned before, the slope of that relationship did not conform to what has been assumed to be the relationship of DASI scores to VO2 peak. So if you looked at a DASI score of 25 in our particular cohort, if you use the standard equation, you would greatly underestimate overestimate what their true exercise capacity would be. So the slope of the relationship is different. So again, pointing to the difficulty of converting DASI scores to VO2 peak values. So how about prediction of outcomes? So this is much more difficult to,
How does this stuff look in smokers versus non-smokers? Because you have a judgment call or a bias potentially if you know the person is a smoker of what you perceive their oxygen should be in potentially. In the sense that
that's a great question. We haven't actually looked at that. So, that's something we should do. Yeah. No, thank you. We did not look at that for sure. And there was about 25%.
Yeah, that was the population, right? But plus your population is 65-ish, right?
Yeah.
So you've got healthier age people that are not sitting at the extreme of COPD in front of you, but at the same time, they're potentially not necessarily great oxygen exchange.
Correct. Yeah.
That you can't see.
Yeah, so that would be great. That is something I will definitely do. We had not done that. So I'm going to try to, so the table showing the outcomes in the paper are exhaustive and complicated, probably not a good way to present the data. So these are sort of overview of the results. So no matter which way you looked at it, subjective assessment, if you looked at any of the four main outcomes, it predicted none of them using any of the methods that's either regression methods or net reclassification, net risk reclassification. If you looked at DASI scores, what we found if you just use regression methods is that it was actually associated with, and mind you, we did not have that many events here, with both death or myocardial infarction as well as death or myocardial injury, and that was confirmed at least with respect to myocardial injury if you use net risk reclassification. So it would suggest at least that if you look at the constellation of events that are more cardiovascular related, then the questionnaire seemed to have some predictive performance there. If you looked at higher NT-proBNP concentrations, which are indicative of poorer cardiac reserve, it was associated with death or myocardial injury, which is consistent with what has been shown in some of the previous studies. And it's also associated with one-year mortality, which is again what we know to be the case if you took non-surgical patients. So it's kind of a test of validity in some ways of our measure. And both of those were consistent when we used net reclassification improvement indices. Contrary to what the folks who are real proponents of exercise testing would suggest, we actually didn't find that CPAP performance predicted any of the cardiovascular events, but what it did predict were moderate or severe complications. But as I mentioned, those were largely pulmonary or infectious events. So it suggests that objectively measured exercise capacity matters, but not with respect to predicting cardiovascular complications. And that was highly significant using either either regression methods or NRI. But there are, of course, limitations with this. Well, this study has others. So we had a lower than expected event rate. I think that's to some extent explained by the selection bias. If you ask somebody to go exercise really hard for research purposes, you're going to get some natural dropouts. But to some extent, if you look at large, less selected cohort studies of inpatient non-cardiac surgery in high-income countries, the event rates for mortality and even myocardial infarction are not similar. So ours is on the lower end of that, but it's not off the scale. Where most of the events occur is when you have surgery in middle-income or low-income countries, or if you're having emergency surgery. That's where a lot of the bad things happen. Elective surgery tends to be safer than certainly historically has been the case. There are some components that are just inherent to pragmatic study design. So the cardiopulmonary exercise testing was evaluated locally. We're doing some secondary work. We're adjudicating that centrally. But to some extent, this reflects what would happen in usual clinical practice, because this is not a gold standard determination by one group of people at a center. This is really what happens when it's done by trained people at their local centers. We had different troponin assays across hospitals, so that there's some variation in performance based on that. But I don't think that would have affected the validity of the results per se, and really this is consistent with a lot of multi-center studies. And some would argue that the inclusion of orthopedic surgery is problematic because perhaps the relationship between fitness and outcomes is different if you have joint replacement, if you have major joint surgery versus other groups of patients. But if you subset it to patients who were just having abdominal surgery, the results are pretty much the same. So from a clinical conclusion perspective, I mean, first is this was a very hard paper to write. I would say, because it's very hard to get, you always like a clean message from the papers, but sometimes the data or whatever the data are. So I think the strongest message is that what we do typically doesn't really work very well. So I think that's probably the strongest message. The more problematic thing is, well, what do you do if that's not the best approach? And it would seem that pending further validation work, and I think where we need more research, if you're focusing on evaluating cardiac risk, then the two best approaches, at least the study would suggest, are either a questionnaire or a biomarker, perhaps separately, perhaps in combination. But if you're trying to predict complications, and these are really predominantly cardiovascular, sort of pulmonary infectious events, and things aside from bad things in the heart, then formal exercise testing may have a role. So there's this idea about that what you're trying to predict may determine what type of measure of risk that you're using before surgery is a concept that at some level seems obvious, but we haven't been doing it very much in patients previously. But and I'll finish off with, I think, some important issues to be addressed. So the first is that even if there's a threshold, if the data is associated with that, people don't view risk tools linearly. You sort of think they want to know, like, about what level should I worry about that. So are they important thresholds? We haven't, that was not done in our primary paper. Are this questionnaire and NT-proBNP complementary? Are they simply substitutes for each other? What complications should we be focusing on if we're focusing on exercise capacity? Because it seems that different measures of fitness seem to matter differently in terms of what complications they predict. And to George's point, what about simpler exercise tests? So this is some preliminary data, stuff that we're actually working on.
Where are you going? Absolutely. Go back to which complications, because you've got a composite sort of all complications.
Yeah.
And I'm working with someone in wound infections in obese women after cesarean section.
Yeah.
And I just wondered, I'm imagining surgical site infections are more prevalent if the person's got like a lot of adipose tissue around their abdomen, they're having abdominal surgery, and I just wondered that, maybe some risk factors are specific to the type of complication and might be more useful than kind of generic thing like how much you walk and so on. Like if someone's got a lot of abdominal fat, they're at high risk of that kind of complication, but maybe not at risk of being admitted or having
exactly. So and I think that's although it seems actually rather obvious when you think about it, that's typically not, people have sort of looked at bad events as a group, but you're exactly right that the things that determine surgical site infections are different from others. But to some extent, I think at a operational level, although people group these together, you kind of, I guess from when you're trying to figure out, it's hard to apply 4 different risk tools for every single thing that you have in a patient. If you have stuff where things kind of group together, at least in a qualitatively homogeneous way, they kind of move in the same direction, then I think operationally that makes it easier in a clinic. But it's always complicated. Like what's interesting is that it's bad to be very obese in a surgical patient, but it's actually way worse is to be underweight. So actually underweight patients who are a bit sarcopenic do terribly for surgery, which is actually the weird thing about all these relationships. But I think trying to figure out a group of, I think what seems clear to me is that certainly this idea of grouping cardiovascular complications with others in one just is not a good way to do this, and we have to think about these things somewhat differently. And the other aspect, I think, is that frankly the reasons why people run into trouble most days at most of our hospitals is not because they have a myocardial infarction, it's because it's surgical site infections and sepsis and respiratory failure. So the reason for badness has changed. I suspect part of this is driven historically because coronary disease epidemiology has changed over time because treatment's better and monitoring's better, but we still focus on that because of historical reasons, but also we tend to study what's easy to measure, and so renal problems and cardiac problems are really easy because you can just do blood tests on a whole bunch of patients. To study surgical site infections is super challenging from a methodological perspective in terms of actually picking them up. So I'm going to go on. So some of the preliminary analyses, but this is very preliminary. So one of the things we found, and this is just a relationship between DASI scores and the risk of death of myocardial infarction, and we don't have many events, but it certainly suggests it may not be completely linear. And if you think there's an inflection point, it's somewhere between 34 to 36, but again, this is in an unadjusted fashion. But interestingly, that relationship is independent of NT-proBNP concentrations, so that it's possible that when you have larger validation data, that if you're focusing on predicting cardiovascular events, biomarkers, and estimates of functional capacity are both important. And interestingly, is that if you look at the relationship between complications, which DASI scores didn't seem to actually predict, that same nonlinear association seems to be there with an inflection point somewhere around 35. But this is some of the work where we're trying to better delineate. So pending more validation work from a clinician's perspective, could you just provide them a threshold? You know, if the score is below a certain level, this is where you should start worrying. But clearly we need more validation work, which may be easier because if you can replicate our study without a formal exercise test, but simply completing questionnaires, the selection bias would obviously be a bit lower because it's much easier to get convince a patient to complete questionnaires than it is to do an exercise test. The question about the simpler exercise test. So we actually did a sub-study. This was led by some of our colleagues in Australia, about 550 of them, and then they completed a 6-minute walk test also before surgery, so between the CPET test and surgery. That was principally focused, and this was the focus of that group of patients, of those investigators, on disability-free survival. So this idea that 6 months after surgery, they would be able to be alive, but not have significant self-reported disability based on the WHO disability schedule. And there was a relationship. It wasn't very strong. But one of the things we haven't looked at was actually its relationship to major complications that are infectious or pulmonary, because if we believe the results of the cardiopulmonary testing results, then it would suggest that if the 6-minute walk test is a proxy measure for an exercise test, then it would seem that the complications we should focus on, if we're going to use this as a risk stratification tool, are probably some of those non-cardiac complications. So questions are what complications to focus on, and once you focus on that, does 6-minute walk test performance matter? And I think if we think about where, if we did a NETS2 or something else where we explore exercise tests further, this is probably one of the avenues we'll pursue. Yeah.
So when you did this CPET, I just wondered, what was the limitation to exercise? Was it cardiac? Because I'm wondering, when you talk about fitness, you're talking about cardiorespiratory fitness. I'm just wondering about musculoskeletal fitness. I'm looking at frailty and muscle performance.
Right. You know, it's so typically the reasons, I'm trying to think about what our CRF showed, was that, you know, they would basically, there was a small minority where they had to stop because of sort of safety reasons, either because of significant changes in blood pressure or ischemia noted, but that was a minority. Most of the time it was fatigue, but what I don't know, and I'd have to look at that, is to what extent you can delineate how much of it is musculoskeletal versus something that was just actually cardiopulmonary. I suspect if the issues on frailty, that we probably had fewer frail patients because there was inherent selection bias for this. And we didn't have other measures of frailty, such as, you know, measures of sarcopenia or albumin or grip strength or any one of those things. So we didn't measure frailty formally there. But I mean, I'd be certainly interested in how you think we might be able to use the CPET results to better delineate that. Or is this something you've done yourself before, or would you have recommendations?
Yeah, I mean, just when you're looking at other exercise tests to use, you know, and there's a lot of physical performance tests and such as stand tests and things that are very simple to do and repeatable, that if it's a limitation, a peripheral limitation or musculoskeletal limitation, there might be other options in addition to other functional exercises.
So I think the thing with CPET is it's typically more pure just a cardiopulmonary fitness type test versus others, which are the things that you talked about, that are those other multidimensional components of frailty. Actually, that's a study where we're doing in older patients that I'll be doing with Shabir which is going to look a bit more at some of those other components such as time up and go testing, grip strength, to get a better sense of that. I suspect if we looked at the spectrum of the typical sort of frailty surgical work, the distribution of these patients is probably on the fitter level than those patients. And so that's kind of if we think about where we think this body of research will go later, where there might be a role for understanding exercise tests a bit more, for its application, certainly in the North American setting. I think there may be a role for the 6-minute walk test, but I think the important thing would be to establish both which complications to focus on, because I think the work of METS would suggest that the complications you focus on matter. But I suspect as well that we would have better fewer recruitment problems because people are much more likely to walk for 6 minutes than come back to do an exercise test. And I think I'll stop there and take any questions. Thank you.
You've obviously looked at sex differences. Can you comment at all about that?
So, I mean, we didn't look, that was on the primary focus of the study. So if you looked at sort of, so if you look at sex-based differences for cardiovascular complications, there was none. For non-cardiovascular complications, which is major complications, women on the average had a lower risk of major complications than men. But I would say that I would argue there's probably still residual confounding on that because there's obviously some sex differences in type of surgery you would be allocated to have. So, for example, women would exclusively have hysterectomies, which are generally lower risk than some other major sort of pelvic operations. So, on a crude basis, they seem to have fewer complications, but we haven't explored that completely. When you looked at data, larger administrative databases, work such as stuff from ITS, even when you have a whole bunch of comorbidity codes, certainly in the surgical population, women actually do better, at least in terms of mortality at 30 days after surgery. And the adjusted odds ratios usually range from about 0.7 to 0.85, 0.9. How much of that is simply residual unmeasured confounding, I don't know. Or whether it's that women on the average have better health-seeking behavior than men when they present for surgery, or the differences in selection criteria for surgery, where surgeons are less willing to offer surgery to men, sort of women who have the same burden of illness as men. I don't know that part, but at least in ours would suggest it's qualitatively similar to what's been shown in the previous literature. Yep.
In your flowchart you showed really early on,
yep.
I was trying to figure out where people went, and there's only one box where they didn't go to surgery.
Yeah.
Because they were getting revascularization or something like that.
Yeah.
So sorry, that's not my question.
Okay.
My question is, so you find things that present these complications,
yeah.
Cardiac injury or whatever,
yeah.
Complications afterwards. So if someone's a high enough risk and it's not really cardiovascular stuff, we wouldn't send, if they're high risk of wound infection or pulmonary problems, you wouldn't send revascularization. So would it be you need to get fitter before surgery, or what else would you do when someone's a high risk?
That's a great question. So I think there's a whole bunch of work on what's called rehabilitation. I think Shabir. Yes. Exactly. So I think there's a bunch of important work in that. I think one of the things that this would, I think, help inform for some is that at some centers, I don't know how much, there's an active prehab program here, Daniel Santamina and Shabir are involved in that. Is that one problem is that there are centers where the people who go into rehabilitation before surgery are kind of patients who really don't need it. So you'll see a 55-year-old executive who's having prostate surgery, and frankly, prostate surgery is not such a big deal, and these guys are pretty fit. It's good, they feel motivated and so on, but I think part of this work would be identifying the groups of patients where that type of therapy should be targeted on. But I think even when you deal with them, to go back to the earlier point, it's not simply cardiopulmonary fitness. They often would benefit from a bunch of other sort of multimodal improvements. So musculoskeletal strength, nutrition, improvements in cardiopulmonary fitness. But that would be the intervention.
My thinking here as a surgeon is very similar along with the previous question. Assuming you can reach your point, which I hope you could, it's interesting research, at which you have whatever credible series of features you identify that are meaningful predictors, then it all becomes, it doesn't go anywhere without the so what question.
Yeah.
So the so what question is how you deal with the results, assuming that you have some credibility that you are dealing with a higher risk population. What do you do? And the answer is going to range all the way from physiotherapy to exercise programs to canceling the surgery to putting it back 3 months. I mean, all these things are going to happen. And that's even for necessary surgery.
Yeah.
But when you start talking about the enormous amount of unnecessary surgery that's going on, which you happen to highlight one of the highest areas in urology, if anything you can do to, the slightest risk, you'd accept a lower level of risk to say, no, we really shouldn't be doing this. Particularly these days with, for example, thyroid, lung, and DCIS surgery.
So I think this is with many areas, people focus a lot more on prediction or risk stratification than on interventions that work. So I think you're exactly right. This is just the first step in attacking this problem. I think one of the reasons why, from a general perspective, we've done a whole bunch of intervention trials in surgical patients. So, probably 10 years ago we haven't, but now there have been multiple trials either that are published or ones that I know are pretty much completed of 5,000, 6,000 patients in large multi-center RCTs. And I would say that I'm pushing just about all of them have not shown any benefit, or in some cases harm. And now it could be that our conceptual framework for the interventions or thinking about them haven't been pretty good. But I'd say that, surgical patients are heterogeneous. There's competing risks. And to some extent, if we treat them like an outpatient population having hypertension apply, take lots and lots of patients and give them all the same drug, I suspect we're going to keep repeating this. So part of, I think, this work would be to help identify subsets of patients where we can target them for interventions appropriately, where the balance of potential benefits outweighs the balance of potential risk. So, for example, I think there's a rehabilitation issue. I suspect, though, that that'll always be pretty boutique because a lot of patients who come unfit, like they've had 50 years to figure out how to be unfit. So there's only so much motivation to figure out that. But so there's work. So, there's much work, and this is some pilot work that we're doing to see if we can modify the kind of hemodynamic care during and after surgery because maybe they have less. So maybe these are the patients that are much more aggressive in terms of their blood pressure and their perfusion targets. Are these the patients that warrant appropriate use transfer to step-down beds? I mean, right now, the argument at the end of the operation between the surgeon and the anesthesiologist and everybody else, but we need step-down beds, is kind of wild guess. Let's to be honest, right? And I think there's a lot of misallocation that occurs, so if we can do that better. And finally, maybe to think even preventative strategies afterwards. So I think some of the things that you talked about the other thing would be actually in some cases delaying surgery or considering options. Interestingly, when the incentive system for payments changes, then this discussion is very different. So if you look at the UK, if you are getting a softectomy, which is by no means a straightforward operation, and you do CPAT and you got an anaerobic threshold of 10, which is awful, they think really hard about whether they want to operate on that patient. And that's probably a good decision. I mean, the difficulty is figuring out when it's appropriate to modify. Like when I've been to some of these meetings, they seem very conservative in terms of what they're willing to cancel to the extent that it feels very uncomfortable to me. I don't know where the truth of the correct position lies, but I think it allows that conversation to be had. But it depends a huge amount, I think, on the incentive systems for people to operate, or like ours is still gained towards just doing more stuff for now.
Yeah, and don't hold your breath for that to change.
Yeah.
And well, it's after 2, so I think we should probably wrap up. Thank you very much. It was great. Thank you.